ask people, and Camilla's going to talk about this. I thought I'd just give you a quick update about the early intervention service in Berkshire, as in April it's been going 3 years in its form now, which seems to have gone very, very fast. The recent developments are around our Sharon for carers. That's been implemented across the whole service, and there's been quite good uptake from our service. It's an online platform where people can seek advice from each other. It's peer-led, and we have lots of information on there. And we're due to go live with the service user Sharon in February, which will be the same model. And I'm sure you've probably heard about Sharon from other services within Berkshire. As we've been going 3 years, we've become quite a data-rich service. We're able to pull data around very specific things about how many patient questionnaires people have been given, and information particularly around the cardiometabolic screening of our patients. As I'm sure you're aware, we've had a sequin for the last 3 years. And it's been a huge piece of work embedding that into clinical practice across the service. And this presentation today is really about our experiences of managing and monitoring cardiometabolic screening, and sharing our insights into that, and exploring how a benefit it's been to work together with GPs to support our patients. So Camilla is the EIP pharmacist. She works across the whole of Berkshire, and she talks really quickly, so we should finish on time. And I'll kick her if she doesn't.
Yeah. We'll try and keep this on time. So I'm not too sure, I assume most of you will know about what a nice concordant EIP service should be able to offer and deliver. So that's CBT for psychosis, physical health assessments, family intervention, wellbeing support, clozapine, carer-focused education, and education and employment support. So we have to be able to have 50% of people who refer to us be engaged in a nice concordant package of care within 14 days of receiving a referral. So we're just going to focus on the wellbeing support and the physical health assessments. So we know that people with SMI are at greater risk of poor physical health, and they have a much higher premature mortality than the general population. So you must be aware that they die on average 15 to 20 years younger. They have 3.7 times higher death rates for ages under 75 than the general population. And because the general population's mortality rate is improving, actually the gap is widening between the people who have SMI compared to the general population. So it's predicted that 2 in 3 deaths of people in SMI are due to physical health illnesses that can be prevented, and these are particularly cardiovascular disease, respiratory disease, diabetes and hypertension. So this just gives a bit of a summary of how many deaths that would be additional per 100,000, so you can think about your practice size, how many deaths that might be for your practice. And so really, the action to address cardiovascular disease mortality has the greatest impact of most people. So there's a thin data set, I don't know if you're aware, that's from GP practice data that was published last year, and it provides even more evidence about health inequalities in people with serious mental illness. This is age and sex adjusted, and the bold numbers show the ones that are significantly different. So the dark green are people who have SMI, and the grey are just the general population. And as you can see, the range of different conditions here, ranging from obesity, asthma, hypertension, diabetes, COPD, cancer, chronic heart disease and stroke. If we look at these in age-specific prevalence, we notice stark differences. So these are broken down in age groups of 15 to 34, 35 to 54, 55 to 74. So you can see that for the 15 to 34 age group, 3 times more likely to be obese than their peers. That age group are also 1.3 times more likely to have asthma, 3.2 times more likely to have hypertension, and 3.7 times more likely to have diabetes. So, as you can see, that's conditions that you wouldn't be expecting 15 to 34-year-olds to have such a high prevalence of things, and this all factors into the cardiovascular disease risk that actually is causing their premature deaths. Now, what we do know is that this data shows that the inequality and death rates for people under 75 of SMI are highest in those aged 30 to 44, and they have a death rate 5 times the general population of their peers. So if we plot these on mortality trend graphs, just taking roughly what the figures would look like, you're looking at a 30 to 34-year-old having more of a mortality rate above a 45 to 49-year-old, and a 40 to 44-year-old having a mortality rate between a 60 and a 65-year-old. So there is stark differences for these patients. So that's at a national level. If we just look at our STP, so this is this is BOP. You can see that the dotted line is for the non-SMI patient, the straight line at the top is for the SMI patient group, and this looks at the mortality. So circulatory, there's 3.4 times more likely to die for circulatory disease in SMI patients in this STP. And you can see the difference between males and females, and so consistently they have greater physical health. They're dying from physical health, some of which are preventative, than their peers who don't have SMI. And this is exactly the same for the Frimley STP. And then you can also have a look at what the life expectancy is for the STPs area. So for the males, they're dying 20 years earlier, and the females only 17.2%. And on the graph on the side, you can see where that STP is lying in relation to other STPs in the area for mortality rates. And this is the same for Frimley. So Frimley has an even bigger gap. The males are dying 22.2 years earlier, and the females only 17.1. So in order to close this inequality and gap, EIP and inpatients and CMHTs, ours is slightly different with higher attainment, is to have a cardiometabolic sequence. So we had to have at least 90% of patients with a psychotic diagnosis receive a comprehensive annual cardiometabolic physical health check and have identification. So it's not just about identifying, it's about providing them an intervention that's going to make a difference. So that is the first sequence, and then the second sequence, or the other two sequences that we've had in addition to this year, is we had to have a target of no more than 35% of our caseload getting more than 7% of their baseline BMI in their first 12 months of taking an antipsychotic medication. The reason it's 7% is that's the line that's drawn in the sand of when your physical health is deemed to be starting to be affected. And we had to have 10% of people give up smoking. And so you can understanding the bits before of why they made us focus on weight gain and smoking cessation, because they're the two most things that we can modify the most to make a difference in people's cardiovascular, reduce their chance of hypertension and reduce their chance of diabetes. So I'd like to say that we met those two. Sadly and expectedly, we didn't meet the BMI. But you know, and for the last 2 years we've met our sequin, and we just wanted to kind of share that actually for us it wasn't about a target, it's about the values that sit behind this target that kept us motivated. You know, it's doing what matters to people, it's helping people to self-manage their health and their well-being, it's about making the most of expertise to ensure that people are getting the right treatment at the right time, and normalising, so asking people to do just what other people you would ask other people to do. So come and see your GP, who are the expert. And ethically, it's the right thing to do if you think about benefits, non-malefits, and justice. So So I'll just give you a bit of an overview. So we had our national audit for psychosis audit in October, which is where all our sequin data comes from. So I just wanted to give you a bit of an idea of what's happening within Berkshire. So you have the national data, the STP data, and this is what's happening in your EIP service. So as you can see, this looks at BMI, how many people are overweight, how many people might be pre-diabetic or diabetic, how many people had problems with blood lipids or a Q risk of over 10%, and who had a blood pressure problem. Well, it hasn't quite aligned up, but don't worry. Anyway, so I'd just like you to, I'll get rid of that because you can't see those. Have a look at those figures, because something you need to bear in mind is that 50% of our caseload in EIP are the ages of 19 to 35. And this was a sample of 84 patients that met the criteria. So we had 49, so 57% of them were classified as obese. We had 8 people having an HbA1c that would suggest they were either diabetic or pre-diabetic. We had 9 people who had abnormal lipids or Q risk of over 10%. And then we had 14 people who had raised blood pressure. Now, I don't know about you, but to me that's quite shocking for actually the age groups that we're looking at. And I think we'd all share that actually these are not the kind of conditions that we'd be expecting to look in this kind of age group and be expecting to see. So the 5-year forward view has a goal to ensure that 280,000 people receive a physical health check and follow up by the end of 2019. And the CCGs have to offer the NICE recommended screening, so the screening that we've been doing, to cover 60% of the population with SMI on the GP register. And this is to be delivered between primary and secondary care. At the moment, it seems that it's possibly going to be a LES across both CCGs. So I hope you've got some understanding of where this is coming from, of why it's so important to be able to offering these, and not only just identify, but be providing interventions that are going to make a difference to people's long-term physical health and ultimately mortality. So it's a cardiometabolic risk assessment, which will be in line. It'll be very, very similar to the NHS health check you give. It's about providing interventions, offering pharmacology if needed, or other support, and just general physical health inquiry. One of the things is it's about making sure in this document it's about working together as a team between primary and secondary care, and we'll go on later to show some examples of where it's been key of working together as extended multidisciplinary team to be able to utilise your expertise and our resources of working with people to be able to get people who can be really difficult to engage into some of the pathways that they need to be able to improve their physical health. So working in partnership will help us all in closing this inequality gap, and we know that by improving physical health we have to address and reduce the impact of health behaviours such as smoking and diet, lack of exercise, smoking, substance misuse, and maybe that people engage in more than one of these risky behaviours. We need to look at side effects of antipsychotic medication, including weight gain, glucose intolerance and cardiovascular effects. We need to look at the difficulties in accessing treatment, so there might be lack of intervention following on from, so people aren't being offered interventions even though they've had the monitoring. There might be a disconnect in a regular approach to healthcare provision, so they won't engage, or you can't get them in, or various different things, but we need to work in a very coordinated way. They might not be compliant with care processes, They might have, the effect of having an SMI might really poorly affect their ability to self-manage. So they might not be adherent to treatment, they might really struggle with some of the interventions that they need and need some extra support. And we also know that socio-economic issues, as well as suffering from mental health condition, makes physical health outcomes poorer. So I just want to share with you a few stories of where together we've made a real difference. So we had a young man in his early 20s with schizophrenia who had an HbA1c of 59, which was requested by his GP. I came across this result that it was 2 months later and there appeared to be no intervention. And actually contacting the GP to see actually what's been going on, what were the difficulties. We actually identified the GP been trying to get him in, but he just wouldn't come in. So actually by just working with the care coordinator, we managed to get that person into the GP, and he got into the care pathway of diabetes and is now effectively managed. We had another woman, a young woman in her 20s, who presented to A&E with visual and auditory hallucinations after starting to take cocodamol for a bad back, and she was started on olanzapine. She got referred to EIP, which we had a look, and obviously to do with medicines, they came to me to say cocodamol, psychosis. And actually going through and looking into connected care and then speaking with the GP, she'd already had cocodamol before, so it wasn't likely to be that, and in fact it's quite a low chance of that happening. We actually, by working with the GP, realised she'd been recently diagnosed with hypothyroidism. And after speaking with the endocrinology consultant, because she was quite unwell at the time, we managed to get the GP just had to write a letter, and they provided some recommendation on starting treatment before being seen in the outpatient treatment between the outpatient clinic. And within 2 weeks of starting antithyroid meds, everything had abated, and she was taken off the olanzapine and discharged back to the GP. Another man in his mid-50s who's overweight, pre-diabetic, becomes unwell again after being medication-free for almost 6 months. He previously responded well to olanzapine. Now clearly, being overweight, pre-diabetic, we don't really want to go near olanzapine. So, because he was quite stressed at the time we started that, we actually started him back on olanzapine for a couple of weeks just to get him calm so that he wasn't sleeping. But we actually then worked with the GP about switching them to aripiprazole, and we'll continue to monitor his weight, and cardiometabolic checks are completed in 3 months to make sure that the pre-diabetes isn't getting any worse. Working with the GP, we've managed to get the person to attend a pre-diabetic course. They're seeing the practice dietetic nurse to be able to help manage increasing his exercise and working on his diet to be able to kind of stave off the transition to diabetes. We've had a young man in his early 20s with a recent and first admission to hospital complaining of erectile dysfunction. Unfortunately, he was discharged from haloperidol, and he wanted to be on a long-acting injection because he recognised the benefit of medication, but knew he was quite, being young, most of us don't like taking medicines every day. So we did a prolactin before looking at going on to an injection, and also the fact he was suffering from erectile dysfunction. That was raised, so we switched him to aripiprazole. Prolactin had normalised, however still experiencing erectile dysfunction. I liaised with the GP because his HbA1c was fine, his lipids were fine, his blood pressure was fine. We agreed that we needed to get a testosterone level done, and that would be useful, so we managed to get the testosterone level done, so the results were with the GP before the patient came to see the GP, and within one session at the GP they were able to confirm there was no organic cause for it and was referred to psychosexual clinic. So just a brief summary, because I think we're running out of time. What helps makes the difference? This is more than just about doing screening, it's about conversations with individuals to understand what matters to them and what their concerns are. It's about teamwork, recognising the need for good communication to plan and organise the most effective care. it's acting on what matters, so recognising and utilising expertise within the wider team, and that does include you guys, and to achieve the best outcomes for these individuals. And it's about having a shared understanding of values and goals. Any questions? Typically, a lot of psychiatrists have a lot of experience with it, so it's something that's quite happy with. You can start it and increase the dose quite quickly without too much restlessness that you can get with things like more preferable, like aripiprazole. If someone's particularly distressed, the sedative nature can be quite helpful. And obviously if people are struggling to sleep, then it can be helpful. So I'm an independent prescriber, and I prescribe across the in EIP as well. So just like the chap that we were explaining, to put him on that for a couple of weeks can help settle and alleviate, but that's fine in the short term. It's just to have a longer term plan about switching. Unfortunately, a lot of times people might come into us, they've gone in straight into the ward and they're not referred to us until they're being kicked out, or they've gone into crisis team, and the trouble is that the damage, the weight gain will occur in the first 6 weeks. So most of the weight gain that someone will gain in the first 12 months of being on antipsychotic will happen in the first 6 weeks, and often they don't come to us before that happens. But I think we're definitely getting better in EIP about trying to care coordinate to identify those people who've been started on olanzapine and to have conversations with people about the possibility of switching. Because obviously if someone's then becomes settled, there is always a risk. There's no evidence to suggest they wouldn't respond to something like aripiprazole, but there's also the evidence that we have that not everyone responds to every antipsychotic. So it's a decision to be. But we're slowly trying to get there about trying to get aripiprazole used as more first line, not only just for its cardiometabolic effects, but for, I don't know if you're aware of the dopamine supersensitivity theory in psychosis, but basically aripiprazole is one of the preferred for first episode because you're not blocking dopamine so much that when you withdraw it, you're actually increasing the risk of a rebound psychosis. But it's difficult because aripiprazole takes so much longer to titrate. You often want to start at lower doses and titrate quite slowly, like minimum of 2 weeks between dose increases because of the akaphysia and the fact that the half-life is so long. And that's the bit that if someone's in an acute situation can be really difficult to kind of balance. But ideally, if someone started on, we'd want to look to switch them, but that's a conversation with that person.
Thank you very much.